So it is my pleasure today to welcome Dr. Arden, who's the director of the Center of Excellence in Maternal and Child Health and also a professor in the Community Health Sciences Division at UIC School of Public Health. Dr. Hendler's research focuses on exploring factors that increase the risk of adverse pregnancy outcomes and examining ways in which the healthcare delivery system can decrease these risks. Dr. Hendler is a nationally renowned leader in maternal and child health advocacy, policy, epidemiology, and public health system improvement, and her research career reflects her long-standing commitment to improve the health of women, children, and families. Please help me welcome Dr. Hendler.
I want to thank you very much for having me today. I am short, so I'm going to stand here, so I'm not hiding behind the screen. And I hope that this is informative, and for some of you, actually, you find it interesting, because I know for some of you who are pharmacists, maybe it's not that relevant, although there's contraception in there, and that's a pharmacy issue. So I'm mostly going to be speaking today about the work of a group of faculty here at UI Health. And so the work that I'm presenting today really reflects the work of myself, but the work of many of my really close colleagues, and that's what's exciting, being part of a very engaged, interactive, multidisciplinary team that works together on a variety of issues, and because of that has been able to get a whole bunch of different grants, some big, some small. So that's what I'm going to be talking about. And the focus is on women's health in the postpartum period. I just wanted to just quickly lay out the reproductive and perinatal continuum. The postpartum visit is just this one little piece, but it's a critical time between the prenatal period, right after the birth, and leading into the interconception period and what we call the well woman period, which if for a woman who's going to become pregnant again, we call it interconception. For other women, it's the well woman period. But this is where the focus of our work. And I'll talk a little bit later about why this period is gaining so much attention. Standard of care is really thought of as 4 to 6 weeks postpartum, and it's important because it's the time when we can think about and address the morbidities that have arisen or been exacerbated by pregnancy. It's a time when we can talk to women about what insurance they're going to have after their 60 days of Medicaid, for example, and where they're going to, what's their medical care home, and where they're going to get care after this period. And it's also a time when we can talk to them about their reproductive goals for the future and to introduce the contraception. I think that the reason this group is really interested is that we're really interested in women, and we're interested in women's relationship to children. So much of the attention in the postpartum period is focused on, of course, the very vulnerable infant. And the needs of women are often not elevated and are often neglected. We also are concerned about the postpartum visit because we know that in certain populations, particularly the Medicaid population, fewer than 60% of women actually get this visit. And the women who don't receive this visit, some data suggests that they're at increased risk of having another pregnancy that's not planned or intended. Shorter interpregnancy interval, and we know that short interpregnancy interval is associated with increased adverse pregnancy outcomes, and unresolved morbidities, things that concerns that affect their health as a woman, but again, if they became pregnant, would possibly put their infant's life and health in jeopardy, and postpartum depression. And I think that people tend to think about postpartum care in terms of postpartum depression. And a little bit later, I'll refer to a study we did here. And women, when asked about the postpartum visit and postpartum care, there was a lot of, I know what that is. It's postpartum depression screening, or I don't need that because I'm not depressed. And I think that we've done a really good job, actually, of talking about depression. We need to do a better job, and I'll talk more about that at the end of this presentation. But for a lot of women, that's what they think of, because we've actually addressed that a lot, particularly in the news. But we also know that this 4 to 6 week visit, which is the standard of care, probably is too late. It's probably too late in terms of when women resume sexual activity. It's probably too late in terms of addressing morbidities, and too late in terms of issues such as women having trouble breastfeeding, for example, and getting a lactation consultant. These data, the next two slides, are from our Illinois Medicaid program, And they're just showing you that fewer than 60% actually in the last 2 years of data here, 2012 and 2013, fewer than 55% of women have a postpartum visit during this period, 21 days to 56 days, which is the HEDIS measure for postpartum visit. So basically 3 to 8 weeks after delivery is what the measurement is in terms of the HEDIS system. And this just shows you the distribution. It looks to be bimodal, that women are, if you look at the first 90 days, there's a chunk of women getting care in the beginning, and then most of the women are getting care within this window of the 21 to 56 days. So why are we focusing on the postpartum visit and postpartum contraception? Like, what happened in the last few years that this has become a major focal point? So a lot more attention and discussion of medical care at home for women. In maternal and child health, we spent a lot of time in the decades of the 90s and the early 2000s thinking about medical care homes for children, and then started increasingly to think about, well, what's women's medical care home, and what's the difference between going to an OB-GYN and primary care, and should women stay with OB-GYNs or maybe transition to primary care, and are they getting comprehensive care and OB-GYN, all those kinds of issues. The field has moved away during this period from a focus on prenatal care, which is a whole other talk that I could give, and that's my passion, to a focus on preconception and interconception care. And so the postpartum visit is, if you think about it, the beginning of that interconception period. So that's another reason why it got a lot of attention. In the Affordable Care Act, there was a provision for well woman care, preventive health services visit without cost sharing. And so that was a lot of attention all of a sudden being focused on this annual visit for women. And in fact, the Maternal and Child Health Bureau, which is the locus of maternal and child health activities in the country, which sits in HRSA, which is the Department of Health and Human Services, made the women's health visit its national performance #1 for the maternal and child health community. And that meant that all these maternal and child health state, what we call state Title V agencies, so every state has one of these, trying to figure out, and they all picked it as the one that they really wanted to work on. What do we do? How do we increase access to well woman health care? And postpartum care in that period became a very logical place for a touch point where they actually have activities going on where they could focus increasing access to well woman care. And then finally, this screening and referral for postpartum depression had become more of a standard of care. And in Illinois in particular, it's been going on for quite a while with attention to it from the state Medicaid agency, allowing for reimbursement of postpartum depression screening with the Edinburgh Postnatal Depression Scale. The other thing I want to say is that during the Obama administration, the CDC's family planning folks really beefed up the regulations and guidelines related to family planning, which have just been trashed by the current administration. That's another story. You could ask me questions about that. But the fact that they did that all of a sudden brought increasing attention to long-acting reversible methods of contraception, both IUDs and implants. And as a result of that, with this increased push to get LARCs, another logical focus was the postpartum period. Because again, that's a place where actually there's a population that you touch. Women who are not pregnant, as it turns out, it's harder to reach, right? I mean, getting women into the annual visit, I just completed a study called the Well Woman Project, and women often talk about that the time that they were most likely to go for care was when they were pregnant, if they had been pregnant before, because there's services, there's money, there's reimbursement for care, et cetera. So it's become a logical spot for a lot of this attention. So given all this, a working group formed here at University of Illinois Health, UI Health, in 2014. I feel like when I put this together, I didn't realize we've been doing this for 4 years. And we decided in our group to focus on the postpartum visit as well as postpartum contraception with a particular focus on LARC. And this is the group. It's myself, Kristen Rankin, who's an epidemiologist in the School of Public Health, Sadia Haidir, who was here in family planning and has now moved to be the head of family planning at the University of Chicago, and Dr. Rachel Kasky, who many of you probably know, who's both in pediatrics and medicine. And we built our agenda on the work of, I had been the co-chair of a task force from the state Medicaid program of CHIPRA related to postpartum care. We were really focused on the transition between the prenatal period, delivery, and postpartum care, as well as the work of one of our family planning fellows. For a while, we had a family planning fellowship here. We no longer have it. We have new family planning docs, though, in OBGYN, and hopefully we'll get the fellowship back. But one of our fellows, Tara Kumarasamy, with Dr. Kasky and Dr. Rankin, took a look at women's attitudes to the provision of contraception at the well baby visit. And they found that of the 200 women that they recruited in the postpartum period, 83% thought that getting contraceptive counseling and or provision was convenient and acceptable at the well baby visit. So that study, we were already thinking along these lines, but the fact that Tara and Kristen Rankin and Dr. Kasky did this really got us going, really moved us ahead. And then Dr. Rankin received funding to look at Medicaid claims data to look at the scope of postpartum care. So we knew that there was that chart that I showed you earlier with fewer than 60% of women getting the postpartum visit. But we really wondered about how that was, being calculated and what else was going on in this in a broader window in the first 90 days postpartum. And to do this study, we broadened our definition in terms of the CPT codes and ICD-9 codes, and we looked at any routine postpartum care, anything that looked like postpartum services such as depression screening, other health screenings, et cetera, domestic violence counseling, anything we could find. And we also looked at any other office visits that were scheduled for non-acute care. So if it was an acute visit, we did not count it. And what we found is that in this period, this was, I think, 2009, 2010, we actually got the data from the CMS. There were over 90,000 visits to 55+ thousand women. Most of them, 81% of them got something in the first 90 days, and most of them had more than 2 or more visits. So 60% had 2 or more visits, and 34% had something in that first 21 days, and 56% in the window, in the postpartum window. So that led us to, and this diagram, you just saw something similar. We did this before the state did theirs. And then once we did ours, they said, oh, maybe we should be looking broader than this HEDIS measure. And so that's basically the same diagram where this bimodal distribution of when women are getting services in the postpartum period. And this the study basically showed us there's a lot more interaction with the healthcare delivery system in this period than you can know from just using the HEDIS measure. And that women are definitely, a whole bunch of women are definitely interacting with the system much earlier than this 4 to 6 week visit. And that many women are getting more than one visit. And where we were moving at the time, we had a Medicaid program that was, the maternal child health folks there were extremely progressive, and they were trying to get us to have these data be used for advocacy so that they could argue for reimbursement of 2 visits in the postpartum period. And then we had a change of administration. Most of them left. That MCH unit was no longer in the Medicaid program. So this all has fallen by the wayside in terms of the state Medicaid program. But the idea was to try to say, okay, we need to, reconsider what we're doing with this, 1 visit reimbursement in the postpartum period. So also then after this, the state Medicaid program asked us to do more work. They really were trying to get us as their partners. And I don't know how many of you, most of you probably do research with NIH. I do most of my research with state and local partners because I really am an applied researcher. And I do some, over the years, I've done some with HRQ and NIH, but my most fun stuff is with I'm an advocate and I want to be working with our partners. So, and the state wants, they want to work, usually, and during the Democratic administration, they usually want to work with us. So I realize that my career trajectory does track with administrations in terms of who wants to fund UIC. So the state Medicaid program funded us to do a series of mini studies. They asked us to do a literature review on the timing of the visit. What evidence is there that this 4 to 6 week visit is the ultimate time for a visit? Why do we have this? And we ended up doing comprehensive review of guidelines in English-speaking middle or higher income countries from the period 2000 and 2016, And out of like 938 documents, we ended up with 8 guidelines. And basically what we found is that, I'll just quickly show you the table, that all of these guidelines, there was no solid evidence. Most of what they were relying on was expert opinion or group consensus that there should be this 4 to 6 week visit or 1 visit in the postpartum period. These are just the guidelines we used were from Nova Scotia, Michigan, WHO, ACOG, France, and the UK. And 6 of the guidelines recommended only 1 visit, but various times. A couple said 6 to 8 weeks, 3 to 8 weeks. But of the 6, 3 said, but you should also consider visits based on the woman and family's needs. So that was the first part of what the Medicaid agency funded us to do. We also, they also asked us, and we wanted to understand what low-income women's perceptions were of the postpartum visit, what they wanted, what their preferences were about the timing and location. And this is where I said earlier that women talked about postpartum depression screening. That is what the first, for most women, it was only 20 women, most of the women said, oh, I know what that is, postpartum depression screening. But they did say that they wanted multiple opportunities for postpartum care, including the idea, which of course we planted, but they responded positively to, of discussing contraception at the well baby visit. And by the way, anyone can stop me or ask any questions if you have any questions, if I'm going too fast. So feel free to jump in at any time. We also were really curious about providers and what they thought about this whole issue of contraception at the well baby visit, what the best location was for contraceptive care, in particular in the postpartum period. And thinking back on it, we were very buzzed and charged about contraceptive care, but that is very siloing too. It is one thing to add it to the well baby visit, but it is still siloing. So we've come a long way. You'll see how we've progressed over the years. And basically the providers reported back to us, and we talked to pediatricians, nurse midwives, family practice, and OBGYNs, that there are lots of barriers for women at the provider level, the patient level, and the system level. They were all very open to alternate models of care, and they did definitely support the well baby visit as a site of care for postpartum contraceptive counseling. There was a little, I would say, more hesitance with care, particularly on the part of pediatricians who don't want to be, they have so much to do in a visit, and they don't want to be responsible for contraceptive counseling. But the idea of, and for care. So there was support, but not clarity on the best way to approach this from the providers. Now I just wanted to take a pause and just say, well, how did we get into this whole well baby visit thing anyway? So we started out with the postpartum visit, and that's where we were, focused, and all of a sudden we moved to the well baby visit. So how did that happen? So it turns out, given the data, most women actually take their babies for care. And so, like 91% of U.S. infants receive visits during the first year of life. That was in 2011, 2012, but it's in the high 90s, in contrast to the postpartum visit, even among like the Medicaid population. And because women come many times, the schedule is constant, there's many opportunities for touch. There's many opportunities for interaction with women in the postpartum period at the well baby visit. And over time, the pediatric guidelines in our country called Bright Futures recommend that providers really inquire about women's health and women's well-being, including mental health care. And of course, some of that has to do with mother-child interaction, bonding, and wanting to ensure safety also for the infant, but also recognizing that, healthy women in and of itself is an important objective. Also, we began to focus on well baby visit, recognizing that this postpartum depression screening was actually happening in a routine way at the well baby visit, at least here in our state, and it's happening in several states like this. And in the fact that there's reimbursement for this postpartum depression screening at the well baby visit really provided a model for introducing women's health care at the well baby visit. And some people would say, well, family practice docs, they see both moms and babies, why do you need to do this? And we argued back and said, that's great, but most babies still see pediatricians. And even family practice docs don't necessarily see the mom and baby at the same time. There's a mom visit and a baby visit. So this is a model that applies to both. And we do have colleagues in a family practice, and I've been saying family planning, I mean family practice, in a family practice network on the East Coast called the Implicit Network, where they're introducing a variety of maternal and women's health into the Well Baby Visit as well. So this is happening not just in pediatric care, but also in family practice. So in the third part of what the Illinois Department of Healthcare and Family Services, or the state Medicaid program, asked us to do, is they asked us to test the feasibility of introducing a very simple reproductive life planning tool at the Well Baby Visit. And I'll show you in a minute what that was. But the idea is that the pediatrician would be asking women about their needs for contraception or their desires for more children. And so we developed a physician-administered tool. We tested it with 55 moms of infants less than 16 weeks. And it seemed to be successful in terms of integrating the tool into practice. Most of the pediatrics, mostly residents, reported that it took less than 3 minutes to implement, and they thought it was pretty easy. On the other hand, we conducted focus groups with them, and they all said, can't we just have this be self-administered? I think that for them, they have so many checklists in the care that they deliver. There's so many issues that they have to cover with a mom that they felt it would be easier if it was already completed by the woman, and then they could review it with the woman. So we took that to heart, and we'll show you in a few minutes what we've done. Let me just say that the CDC on its, well, hopefully it's still there, but it was on its website, their reproductive life planning tool just basically asks women, how many children would you like to have, and how long would you like to wait until you or your partner becomes pregnant. There's something also called the One Key Question, came out of Oregon, where you just basically, do you want to have children in the next year? Just real simple ways to get this discussion going, and these things have actually been taking off in a variety of settings now. Our tool, which I think is really very funny looking back on it, we call this a simple tool. It's so complicated because we were trying to not only have them ask the question about, do you plan to have more children in the future? We were also trying to have them give information about contraception. So we had this complicated schema if they said yes, if they said no, and if they're using contraception, if they're not using effective contraception. So actually, the fact that they completed this in 3 minutes, I think, is kind of a miracle. And it's pretty funny to me now looking back on it, how complex. You'll see our current tool, how much easier it is. But this is what we had come up with. And they were still pretty positive, so it's hopeful. So at the same time that we were finishing that up, Sadia, who was a family planning fellow, had access to funding from the Society of Family Planning that allowed her to tap into funds that you can't get unless you're part of this network. And so she decided to apply for funding in which we would do reproductive life planning at the Well Baby Visit, but literally have somebody on site to, if a woman wanted contraception, to deliver that contraception services right then, right after the Well Baby Visit. And she was funded, and essentially all mothers of infants under 4.5 months were approached, and it was actually a trial. She had an intervention arm and a control arm, and she successfully recruited almost 500 women, half and half essentially. Overall, the whole trial, women liked this idea of contraception at the Well Baby Visit a lot. And most said they would definitely choose it if in the future. Either they definitely or probably. So, but in the intervention arm, most women said, yes, this is great, but only 28% of women stayed. And that's because they said, if you had told me about this ahead of time, I would have planned my child care. I mean, there's always issues of giving women care when they have their infants or children with them, which we do not have a good system for at all in this country. And so the results were disappointing in terms of uptake, but we learned a lot about the fact that you have to plan ahead, and it's not necessarily, not necessarily that you have to have the provider there, but there may be other system approaches that we could use that facilitate the uptake of contraception in the postpartum period, particularly for women who don't go to that postpartum visit. So before I get into what we're doing now, I just want to say that our group kept on going with all these. And Kristen Rankin and led by Kristen got a seed grant from the School of Public Health to look at this concept of informed choice. So I don't know how many of you know what's going on with LARC. Okay, so there's this two-edged sword with LARC in some ways. You can see LARC as a way to really empower women to, have contraception that's going to give them an opportunity to delay pregnancy for as long as they want. And the other side of this is, are women being pushed? Is this LARC sort of the new sterilization? There's so many political issues around this, and there is really also a sense from women of color, led by the reproductive justice groups like Sister Song and Black Mamas Matter, et cetera, that just concern about LARC being shoved down people's throats without real informed choice. Yes?
I'm so sorry. I'm a lay person. What does LARC stand for?
Long-acting reversible contraception, so either IUDs or implants.
Thanks.
Okay? And so there's a lot of really interesting stuff going on. We have this whole history in our country of sterilizing low-income women and low-income women of color. And because of that, we have a 30-day waiting period for sterilizations in the Medicaid program. But now, women who want to get LARC, it's called immediate postpartum LARC, there's this barrier because of the same issue, making sure that there's informed choice. And there's a lot of discussion around, if we give women 30 days for sterilization to think about it, should we be allowing women more time for LARC? Whereas a lot of the advocates would say we should be doing it right then, So there's this real tension between really wanting to give women power over their lives, but also between social control. And these talks and conversations are being played out. Now the conversation is, should we change that 30-day waiting period for sterilization and make it more like LARC? So that's another conversation that's happening. But anyway, Kristen, one of the first states, the southern states, South Carolina and Georgia, were some of the first states to allow for IPP LARC. And what does that mean? It means that the billing codes, those of you who are pharmacists, you know all this, with the access to LARC is a big deal, especially to IUDs. You have to have them stocked, and you also have to be able to bill. And if a woman is she's delivering, and then you're also giving her an IUD at the same time, what's the billing code? So Georgia and South Carolina were some of the first states, their Medicaid programs, first states to figure out how to do this, to disentangle the LARC from the delivery. And interestingly enough, people would say, well, South Carolina, Georgia? And I always say to my students, you have to always think about these things. On the one hand, that's a very progressive move on the part of South Carolina and Georgia. On the other hand, they don't want poor women having babies. They want to make it easy, right? So you have to think about what are the other factors that sometimes propel a very conservative state to do things that look to many of us as progressive. But there's always something, there's a two-edged sword there. But anyway, Kristen knew that Georgia was one of the first states, Kristen Rankin, Dr. Rankin, and she got permission to do a follow-back study of women who got IPP LARC and women who didn't, and to see if their choice was informed. And we're just about to, we have a first paper coming out from that study, and it seems like most women felt that they had informed choice. Interestingly enough, because of all these issues with the IUD, most of the women were getting implants. The other study, and this is ongoing, is so states like Georgia and South Carolina figured out this Medicaid fix, but other states needed to learn. And so ASTA, which is the Association of State and Territorial Health Officers, that's all the folks who run state public health departments, like our guy Shah right now. All those guys, all those people have an organization, and that organization paid for a learning collaborative. And learning collaborative is to figure out how do you implement a change like this. And it seems like, what's the big deal? But we're using implementation science methods to really develop the processes so that all the states can learn from each other about how you change your billing codes, how do you educate providers, how do you educate women. There's many steps in the process. And they've moved beyond IPP LARC to just contraception in general and reimbursement for contraception. And this is still ongoing. Okay. Any questions so far? I know I've touched, I can't restrain myself in talking about a million topics at once. Yes?
I actually do have another question.
Yes.
I'm 4 months postpartum, and I had asked for immediate postpartum LARC, and I was encouraged against it because they said it would interfere with breastfeeding.
Yeah, so that is not my understanding. And Ellen, do you want to respond to that?
I think it's not.
This is Dr. Mason.
I'm an alumni of here, but I am a county for the most part, but I'm at the school. It's not well studied. I mean, any progestin increase might possibly interfere with milk production, but it might not, especially if you do all the right things for breastfeeding in terms of baby to breast, frequent nursing, blah, 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 blah. So the importance of not getting pregnant kind of, I think, is greater than the theoretical risk. Yeah. So they didn't let you have?
They told me that, so I chose not to until my 7-week visit.
Huh. Okay.
Yeah.
And you would still get it.
Yeah, way in the back, I see somebody.
I was just going to comment, like, were you only interested then in a progestin only?
Yes, correct.
Right, because the Paragard is.
The other one is, right.
Hormone free.
Right.
But I think it's just representative of uninformed counseling at the time of birth, that people don't really understand the medications, and that typically it doesn't have much of an effect, but that it can. And, you know, if you do other things to well-establish breastfeeding, then you're probably going to be okay.
Right.
But,
thank you. Yeah, and that's partly what this learning collaborative is about, because there is all this misinformation about from providers, from women, consumers, et cetera, and training to make this possible. So this is still ongoing. Yeah.
I was just thinking with the well baby visit and the fact that, you know, since we don't have paid parental leave in this country, you know, the majority of moms go back, you know, within 4 to 6 weeks. So is it always the moms doing the well baby visit, or is there another, you know, dads, other caretakers, sort of how those trends?
Right. Well, that is a good point, but it, you know, even what we've found so far, it's mostly women, it's mostly the moms, but there's sometimes, you know, a grandma, an aunt, a dad, sometimes more than one person also comes.
Right. So
Yeah.
I was thinking that, you know,
Right.
the 6 week for a lot of, you know,
Yeah.
it's different when you work for university, but for
Right.
most of the world, that's when people are actually like re-entering
Right.
the workforce. If
Right.
not before.
And some
Yeah,
are,
not the world.
right, and some are way earlier, right,
Yeah.
because they can't afford to have unpaid leave. Yeah.
Yeah, or
Yeah.
might not be able to take time off work to
Right.
go to the visit.
Exactly. So if they're going to do anything, they're going to go to the well baby visit, not their own visit. That's the whole thing. That's why there's such a low, you know, number of women going to their own visit, because they feel like I'm fine. So we decided after the project was ongoing at Society for Family Planning, when the idea there of bringing the provider, the nurse, it was a nurse clinician, to the well baby visit is not really sustainable in terms of a system change. And yeah, so we, Dr. Kasky and I really said, you know, let's go back and figure out another sort of more sustainable model to do this. And what we did is we thought about it and thought about the idea of just, you know, a referral, no big deal, doing the reproductive life planning, a tool, have it be self-administered, have it be on the back of the Edinburgh, so it's readily available. Everybody gets it in the waiting room, and then let the pediatrician quickly review it and refer. In our first submission of the R03, the project officer loved it. We had a really good percentile, but a couple of the docs said, how do we know if women are going to go? And just handing off is just not sufficient. And we knew that too. We didn't really love it, but we were trying to come up with something that was real world and not just, you know, pie in the sky, you know, in an academic setting, something that could actually be sustainable. So we, in the next rendition, which is funded, we decided to basically offer women the next time their baby was coming, a same-day appointment or something sooner if she desired that. And that's what this R03 is about. And we're only looking at women who come at the 2-month well baby visit, partly because we didn't want to discourage women from going to the postpartum visit, and we didn't want to even get into the complexities with the reviewers to explain that we weren't going to, and we were going to refer some women back to the postpartum visit and someone to just well woman care. It was just too confusing, so we stuck with the 2-month, which is 8 weeks, and we're looking at 6-month uptake of any well woman care and contraception. We're also, of course, talking to providers at the end about barriers and better ways to do this. So systems approach, we're excited about marrying this Edinburgh postnatal depression scale with the reproductive life planning tool and this idea of giving women a future appointment on the same day or earlier. And here's our simplified tool. Women are filling it out themselves. It's a lot easier. Have you had a healthcare visit since delivery? How's your general health? Planning on having more children in the next year? Currently using any birth control? Would you like a referral for any reason? Very simple compared to that first one. This is like, women can handle this. And then we've just started. So what our method is, we're doing a control arm, a 6-week washout, and then we're doing the intervention. So we've just started recruiting for the control arm, and actually we're doing pretty well. We've got, out of the 28 women approached, 23 said yes, and they have a survey, baseline survey and a follow-up survey, and the intervention arm will start probably in the fall after the 6 week. Yeah.
What's your target sample for control and introduction? So
these are women who are coming to the 2-month well baby visit with their child. So, and we don't have an older than 18. Yeah.
Do you have like a sample size?
So this is a totally tiny little nothing pilot study, 50-50. In the power, we basically said, we knew we didn't really have power. So we just said, we're getting estimates for an R01, and they bought it. It's like, they give you no money, $50,000 for 2 years with the ICR. So it's $30,000 for the 2 years. Yeah.
Are you using the EPDS because it's what the hospital's already using?
We are, but I'll tell you more about this other thing that we're doing with the CAT-MH in just a minute. Okay, so then we said, here's something that happened. So we're using this EPDS, the back. Now it turns out we're stapling, not putting it on the back. And I was thinking about going in for a grant, and it was from DHHS. And so now their priorities are obesity, mental health, and opioid. Mm-hmm. And we were thinking about taking this grant and moving on. And I thought, mental, how does this fit? And then all of a sudden it occurred to me, we're not doing anything with the mental health data. We're getting we have access to this EPDS data, and we're not even looking at whether depression affects women's uptake of our intervention, uptake of contraception, et cetera. And I was like a light bulb went off. And as a result, I approached colleagues in psychiatry, and we now have a whole other research agenda going. So just got a seed grant to use the depression data to look at the relationship between the depression and women's desire for more children, their use of physical and mental health care and contraception. And we just got funded yesterday. And the idea is to do a integrated intervention to look at basically developing an intervention that addresses women's mental and physical needs and the infant needs tested through an R01 mechanism. And we've introduced 2 new members to our team. Many of you probably know Dr. Pauline Mackey, and Dr. Melissa Wagner. And it just all happened in the last 6 to 8 weeks. We're very excited. We've had a million meetings since. And our idea, to be honest, is to create a 2-generation clinic here at UIC. That's our plan. And so some of our potential people to help us with funding are here today to hear more about this. We really want to have a unified medical home. It's so just even starting to talk about this here at UIC, UIH. Just the billing issues and people's billable time and space issues. All this stuff is a huge problem, and trying to figure out where can we do this. But we think we're going to start our pilot. Our goal is to do it with women who score high during prenatal period for depression, and also women who start care here at UIC after 24 weeks. To tell you also, as part of the seed grant, because we're getting ready for the R01 already, even though we just started meeting 6 weeks ago, we are going to validate the EPDS screening with something called the CAT-MH, which is a much better way of getting at depression, and it picks up more women than the PHQ-9. And so we incorporated that quickly into our seed grant funding, and we've actually got the IRB approval and started doing it without funding in our the control arm of our R03 already. So we're all very excited about this, and we want to really have a unified care delivery system and really want to be able to improve outcomes for women and children in a unified way. It's ridiculous that we were even thinking just contraception at the well baby visit. It's just depression. It's just too siloed. So that's our goal. We're real excited about it. And just to summarize what we've done, and we can have a more open discussion. We think we've done a lot of work to do a whole bunch of diverse projects with basically no money, little tots of money here and there. Probably the biggest grant was the Society of Family Planning grant, because it actually paid for a nurse to come to the well baby visit. But our whole focus is system level redesign. We really don't want this to be tinkering and academic. We want it to be something that can really change systems so that other systems can adopt what we're interested in. And so far, what we found through all our work is that the whole issue of contraceptive decision-making, it's a process. It's not a one-time deal. Women need multiple touch points. You can't just, expect that, not every woman, it's going to be good for them at delivery. Not every woman in the first 2 weeks is ready. And so we have to really honor where women are at in the process. We have to make sure that we honor informed choice. Probably we should be reimbursing for more than one visit, both through the Medicaid program and insurance. Medicaid is usually the leader, so the idea is if Medicaid will do it, eventually insurance picks up, private insurance. Lots of women support the idea, the women we've encountered, of getting family planning services in conjunction with pediatric care. We know that they've already embraced the depression screening. That's been going on for a long time. Seems like pediatricians are definitely willing to do something in this period, but they want it to be easy for them, given that they have a laundry list of things to take care of, and it makes complete sense. And that we really have found that just the idea of just adding this contraception to the well baby visit really is not sufficient, and we really need new models, new integrated models. And this is me. I'm a little 2 minutes early, but if you have any questions for me, comments, I'm happy that there are some clinicians here who can answer some of the more clinical questions. This is why I have clinical partners. Any thoughts? Yes.
Simple question. Going back to two things that you presented. So in your review of the guidelines, I found it a little bit disappointing. I think you mentioned 3 of them said they should be considering the woman and family's health needs and the determination of timeline.
Yeah.
One would hope it would be more than that.
Yeah.
But I thought that linked very interestingly to the bimodal distribution that you and the state Medicaid agency found. So did you or your team or the DHHS team look at all at the other parts of that distribution to see what was driving the access to care there? If it was sort of gynecology, urology issues, or if it was different types of care?
We do have the data like for every woman's visit, but what I don't have here, and I can't remember, is the breakdown of what in those 3, remember there were 3 categories? There was the routine visit, there was postpartum services, and then there was this sort of hodgepodge of other care. And I don't have the breakdown as to what was in those other, like in the first distribution especially. I just don't remember. It's a great question though. Thank you. Yeah.
I just had a question. Your self-report measure for reproductive
Life planning?
Yes.
Yeah.
I was just curious, it looked like the last question, you had listed out maybe 8 different forms of
Contraception.
Yes, contraception. And I was just curious, this is just a comment, and maybe, do women, are they aware of what all these options are?
I am not completely sure. I think they know a lot of them. I think they know, the pill, the shot. I mean, we put the sort of the language that people are using, insert in the arm, depot shot, they know that. I think probably, I bet you the IUD is the least known. That's the one that everyone's pushing now, but I bet you that's the least known.
I mean, because I find this all really interesting, but just with literacy being an issue,
Yeah.
Maybe that works fine, and if it does, that's great, because I know nothing about this area. But just from kind of a survey development thing, if you find women leaving that blank, or the information you're getting when they talk to the provider is, you might think about getting some feedback on that to understand how you could present those options in ways that would be more meaningful to women. Because right now it's very provider-centric, I think.
Okay.
Maybe I'm wrong though, because as I said, I know nothing about this area per se, but it just might make it easier and faster for them.
Mm-hmm. I think that's a good point.
Because they might be thinking about it in a different way.
Okay.
I want a pill. Somebody say, no.
The whole issue of asking about contraception, and we aren't even asking if they're sexually active. There's a whole series of questions that you could be asking that we're not asking because we don't have room and we want this to be quick and dirty. And it's more for the provider to quickly say, no, do you want to be, or if somebody does say, I'm just using condoms, you know, it's really just to spark a conversation. It's not meant as a real data point.
Well, and as you're correcting me to say this is what they're currently
using.
using.
Yeah.
If someone has an IUD, they know what an IUD is.
Yeah, exactly,
So
exactly.
it's not asking, do you want this?
Yeah.
Question.
Yeah, right.
Yeah,
And it's
no.
really more for conversation as opposed to, we're not even using these data in any way.
Okay.
I
Yeah.
read the question mark.
Okay, yeah.
Was there any specific training for the pediatricians?
We do train the pediatricians.
So that they
So, and we will
can-
again now in our intervention, yes, definitely, to use the tool. But the thing is
But
that.
for the contraception, I mean, they're reviewing, if they're.
Yeah, they will have that as well. But in general, I mean, what we found in the first round is that they didn't want to know on some level. They have too much going on. Yeah. And so they want to be able to just quickly, but there's going to be, and there was information provided to them then, there's going to be now, but they want to be able to just quickly scan, and they're hoping, I mean, my sense of this, they're hoping people don't ask them questions about it. This is what their biggest hesitation was. If she sees this, she's going to ask me and I'm not going to know. Even if you teach me now, I'm not going to remember. And it's interesting. So we'll see how that part goes. But the idea is that we want it to be something where they can scan, say, I'm not the right person to talk to you about this, but we would like you, if you would like another visit with somebody who can tell you more and help you, essentially. That's the idea. Because they really made a big fuss about not wanting to get into contraceptive counseling. For good reason. I mean, they had all this other stuff to do with the babies. Other questions, thoughts? Yes.
Just in general about some of the earlier stuff in your presentation about the postpartum visits. I know the research shows that like doing earlier visits and more visits doesn't necessarily improve morbidity and mortality outcomes for women or children. But I haven't found anything. This is a legit question. Is there anything about the content of those visits or the training of the people conducting those visits? Because when I read the research, I'm like, well, just because you give a visit doesn't mean it's a quality visit. It doesn't mean that it had the content that was needed or that it met the needs of the person in that moment.
Absolutely. I mean, I haven't seen a whole lot, and just in general, we know that the whole prenatal care conundrum, everything that we do there is measuring utilization, not content and quality. There aren't really great ways. I mean, there are special studies people do, right? So, you know, people can go back and abstract medical records, et cetera, but to routinely figure out how to make sure, how to measure quality is just, I think, in general, extremely difficult. And I think we've been doing this longer in terms of prenatal care and haven't figured it out, but I think that's exactly the right question. What are they getting? So we got some of that by, and I wish I could remember the breakdown, that they were getting various things at these visits, but to not have it be comprehensive isn't going to be that useful. On the other hand, it is a touch point. So you're hoping that there's some interaction that maybe gets something done and gets them to the next place. But I think in general, that's a huge issue. And the content of what they're getting prenatally and in the postpartum period is not well documented. And we know there are racial and ethnic differences, though, definitely in what people get.
If there's no other questions, thank you very much.
You're welcome.